Hello everyone and welcome to today's webinar. I'm delighted and honored to have Dr. David Stukus from Nationwide Children's Hospital in Columbus, Ohio here with us today to talk about asthma and food allergies, what we as parents need to know. This webinar is offered by Kids with Food Allergies as part of its Education Outreach Program. I'm Linda Mitchell, Senior Director of Kids with Food Allergies, and I have the privilege of being your moderator again today. Presenters for all of our webinars are doing so as volunteers without compensation. On behalf of KFA, I'm very grateful for Dr. Dave to donate his time to be here with us. I have a few housekeeping details to run through with you while we do some polls. First of all, today's webinar is made possible through an unrestricted education grant from Thermo Fisher Scientific. We rely on donors and corporate partners like Thermo Fisher Scientific for the financial support that enables us to develop education programs for families. Next, please remember that this webinar is of a general nature only and is not medical advice. You should consult your own physician for any medical advice you seek regarding food allergies and any other medical conditions. And we are not trying to imply that any food, ingredients, or products we may mention today are safe for you or for your family. You need to consult with your own physician, and with regard to foods, of course, to always read labels and to verify their safety for your family. Today's webinar will be recorded. We also have a very large audience here with us today, and so for this reason you are in listen-only mode, but we will be running some polls like you see above, so that you can type in your questions and we can try to answer them again later. Later in today's webinar, we will stop to give away some free gifts from two corporate supporters of KFA, Enjoy Life Foods and Dr. Lucy. The recipients of these gifts will be picked randomly from those still in attendance later in the webinar. And when we end this webinar, you'll see a survey. Please share your impressions with us because we take your feedback seriously and to help improve the future direction of this webinar series. So today, now I'd like to introduce Dr. Dave Stukus. David Stukus, MD, is an assistant professor of pediatrics in allergy and immunology at Nationwide Children's Hospital in Columbus, Ohio. Dr. Dave is also on the faculty of the Allergy Fellowship Program at Nationwide Children's Hospital and serves as the director of the Severe Asthma Clinic there. Dr. Dave has a special interest in caring for families with food allergies and also serves as a medical advisor for kids with food allergies. You can find Dr. Dave on Twitter at AllergyKidsDoc. So Dr. Dave, thank you for joining us today. I'd like to hand over the poll results to you so you can go over those with everyone and then get started on your presentation.
Oh, wonderful. Thank you so much, Linda, and I can't express enough appreciation to Kids with Food Allergies as well as AFA for the invitation to speak with you all today. And thank you, everybody, for tuning in. I hope that this will be a helpful presentation for you. So before we get into the nuts and bolts of my presentation, we'll just go over some of the poll results. And it looks like almost everybody joining us today is a parent, and then we have some school nurses in the audience as well, so that's wonderful. And looks like we have a spectrum as far as the age of the youngest child with asthma. A lot of 4 to 10-year-olds with a little bit of infants and toddlers thrown in as well as some teenagers. So great representation there. And then everybody has food allergy just about, which makes sense. Most people have asthma, so that's good to see because that's what the presentation is about. And then, of course, a lot of people have environmental allergies as well and eczema. We're going to touch upon some of these topics as well. And I think that was our last poll. So I will take over now. And okay. So hopefully everybody can see my screen. And what we're going to talk about today, we're going to focus the first part of the talk on asthma. We're going to talk about the signs and symptoms of asthma. We'll also discuss treatment of asthma as well, which is very important. Then we're going to delve into the relationship between food allergies and asthma, risk factors and the such. And then towards the end we will talk about asthma in the context of food allergy reactions. And a lot of our advanced questions actually have to deal with this. So this is a complicated issue that we're definitely going to discuss today. And so before we get into it, the National Heart, Lung, and Blood Institute developed asthma guidelines. These were first developed over 20 years ago, and they've been updated twice since. The last update occurred in 2007. This is really for anybody who takes care of patients with asthma, from primary care physicians to asthma specialists. And I like to highlight this statement because this really is what the goal for anybody with asthma. And simply stated, it's to help people with asthma control their asthma so that they can be active all day and sleep well at night. And if anybody's interested in reading the entire 441-page document, there's a link for you to click on. I don't recommend it unless you have insomnia. So why do we worry about asthma? Well, this is the #1 reason for chronic illness in children. Most estimates have about 10% of overall children having asthma and up to 30% of children living in inner city populations. It's increasing in prevalence, along with environmental allergies and food allergies as well. So we're seeing a rise in all of these over the last couple of decades. Poorly controlled asthma leads to a lot of missed school days for children, and it leads to a lot of missed work days for parents as well. And if any of you have ever had to stay home with your child because they were coughing and you had to administer albuterol treatments throughout the day, you know that this can be a big problem. Now, asthma, if you take the average classroom of about 30 children, about 3 children every classroom will have asthma. This is just according to the general population. Now, estimates for food allergy in the average classroom, about 30, is between 1 and 2 children, depending upon what data you look at. So they're both quite common. Now, what is asthma? It's important to really understand what's going on. So most of you are aware that asthma is a disease that occurs inside the lungs. At the center of it is what the slide shows. It's hallmarked by inflammation. There's chronic inflammation and irritation of the lungs that's present every second of every day. And patients experience variable and reversible recurrent episodes of airway obstruction. So what this means is it's not that one bad episode of cough that you experienced 3 winters ago. It's a pattern of respiratory symptoms that occurs over time, and it reverses and you go back to kind of baseline. Now, in regards to the breathing difficulty and the airflow limitation, it's a very basic kind of graphic here, but I love it because it really highlights what's going on. At the heart of this is constriction of the bronchioles, or the breathing tubes. So the muscles surrounding the breathing tubes where you're trying to get air inside the lungs squeeze and tighten and make it difficult to breathe. The airways are also very twitchy. So it doesn't take much for the airways of somebody with asthma to start to spasm and constrict, so it makes it difficult for them to breathe. And as you can see from the diagram on the right, you can get this really sticky mucus that can be formed, and it's very difficult to clear once it starts forming. So all of this happens during an asthma attack. Now, what does this really look like if you're a parent or if you actually have asthma yourself? So it can present in a variety of ways, including cough. One of the most common symptoms of asthma isn't actually wheezing, but it's coughing, and a lot of parents don't understand that. It's persistent cough, 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 all day, especially at night. In fact, if I see a patient who has persistent nighttime cough, asthma is at the top of the list of things to worry about and consider, especially if you're waking up at night because of coughing or difficulty breathing. So if it actually wakes you from sleep once you've fallen asleep, that's very predictive of actually being due to asthma. Physical activity can provoke symptoms, so sometimes it's coughing and wheezing, but there's a big misperception in the general community that not everybody with asthma actually has symptoms when they're exercising. So you can have terrible asthma, but you can play sports and be fine. On the reverse, you can have mild asthma, but your only triggers when you actually exercise. Certain seasons. This, right now, is the worst time of the year for asthma in the United States of America. Children went back to school within the last couple of months, so viruses are starting to circulate. Here in Columbus, we have our first documented cases of RSV, which is really nasty for anybody with asthma. But rhinovirus and parainfluenza virus, which cause the common cold and croup, respectively, have been very common for the last couple of weeks. The weather gets very goofy. So we have a cold front moving through right now in Ohio that's causing our temperatures to drop about 15 degrees in one day. It's been very rainy. Those rapid fluctuations in temperature can cause problems as well. If you have allergies and asthma and you're exposed to something you're allergic to in the air, then you can have coughing, wheezing, or chest tightness. Common examples would be during certain seasons. So if you have tree pollen allergy, you're going to have issues when you're outdoors in the spring. Grass pollen is going to be in the summer. Ragweed will be in the autumn. And mold is prevalent when it's damp and rainy like it is right now in Ohio. Also, if you have cat or dog allergy, and then also dust mite allergy can provoke that as well. Colds. Now, coughing with colds is common because a lot of people produce a lot of mucus that then runs down your throat, tickles your airway. It's a natural process of the body to try to cough it up and clear it. But for a lot of people with asthma, that irritation can actually trigger that spasming of the muscles, and they can cough for a week or more after they have a cold. And then really, I like to cheat as much as I can. So if you have symptoms such as coughing, wheezing, shortness of breath, and you've tried treatment with a rescue inhaler such as albuterol, and it makes your symptoms go away, that's probably asthma. Now, symptoms can vary. So you can have persistent and chronic symptoms. You can be sick every single day with significant limitations. You're missing school or work. You can't exercise, walk a flight of stairs. You can't sleep at night, and you're miserable. But most people with asthma actually feel fine most of the time. And then they have very discrete and sudden onset of symptoms. And this can be very difficult to manage. I've encountered a lot of patients that are completely fine, and then they have one specific trigger, such as a bad viral illness, and they end up in the emergency room or the hospital, and that happens one time a year. So that can be very difficult to manage. Now, asthma triggers are very important for anybody with asthma to identify and understand, because if you can reduce exposure, it can make you feel a lot better. So anything that can provoke airway hyperresponsiveness or that twitchiness of the airways is a trigger. It can be inside the body or outside the body. Everybody with asthma has triggers. Sometimes they're not quite as evident as they may be with others. It could be one specific trigger, such as exercise or, say, cat dander, or there are a lot of patients who have multiple different triggers that can cause them to have symptoms. And then you can have acute onset sudden symptoms if you have cat allergy and you go to grandma's house where she has 8 cats and you walk in the door and you start coughing and wheezing. That can be your sudden onset one trigger. Or for people who have multiple allergies or, say, dust mite allergy where they're exposed every single night, then they can have more chronic symptoms due to exposure. Now, some of the common triggers include upper respiratory infections. So this is a big deal during the school year. Typical story is going to be I get a runny nose and within 12 to 24 hours, cough, 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 potentially end up in the emergency room or have a severe asthma attack. We already talked about exercise, which can be a trigger for some people but not everybody. Cigarette smoke is a significant problem in our society, especially for children, even adults who have asthma. Any exposure to the scent of tobacco smoke can cause problems for people with asthma. It's not just inhaling the cigarette yourself or even seeing the smoke or inhaling the smoke, but if you can smell it, you're inhaling chemicals that are present inside the cigarette. And depending upon what you read, every cigarette has at least 2,000 to 7,000 different types of chemicals inside of it, which can potentially cause worsening irritation and inflammation of the lungs. If you have allergies, you're exposed to what you're allergic to, such as cats and dogs, that can trigger it. We already talked about the weather changes or just damp, rainy weather by itself. Cold winter air is a significant trigger for asthma because the air quality in the winter is very dry. And for some people, breathing in and inhaling that dry, cold air can actually provoke the spasming of the muscles inside the lungs. Any scented products, such as perfumes, colognes, cleaning products, bathroom sprays, scented candles, wood-burning stoves, incense, any of this can provoke asthma symptoms. Air pollution is a big problem in inner-city populations, especially when the pollution kind of sits in a valley and can't disperse from the wind. This is a picture of a dust mite. I intentionally tried to find the most disgusting picture of a dust mite I possibly could. This is what they look like. Thankfully, they are microscopic and we can't see them, but we all have them unless you live in very high altitude areas like Denver. Cockroaches can trigger asthma symptoms for some people. And there's a study I just read that actually shows that rodents are a big problem for inner-city asthmatics, and then tree pollen and outdoor pollen as well. Now, in children, most common asthma triggers are upper respiratory infections and colds, and then changes in the weather. So spring and autumn are the terrible times of the year for most children with asthma. Frequently, exercise can do it as well, and then exposure to tobacco smoke, and a lot of children with asthma also have allergies. Now, in regards to management of asthma, there's a couple very important concepts. One is quick relief medicine. So we'll talk about this in another slide, but this is albuterol. And I like to say that if you don't need to use albuterol, then you don't have asthma. So albuterol is often prescribed for relief of symptoms due to asthma, and sometimes parents are told only use this in an emergency. I hate that because what that does is that makes you wait until it's too late. Albuterol works a lot better the earlier you use it. Controller medications are indicated for some people because this really treats the inflammation involved with asthma. We'll talk about this more in a little bit. Obviously, if you can identify your known triggers and avoid them, then hopefully this will prevent significant symptoms from occurring. An asthma action plan is very important for communicating the treatment plan as well. And then regular follow-up appointments. Now, this is a hard thing for a lot of families with, who care for children with asthma because, as I mentioned before, they feel fine most of the time. So a lot of parents say, why do I need to go see the doctor if they're doing great? What's he going to do? Well, it's important to make sure we're not missing anything. It's also important because sometimes we have to adjust the treatment plan, and sometimes things change with time. So even if you're feeling fine, making sure you get to the doctor on a regular basis for checkups is important. Now, the goals of therapy are kind of basic and simple, but they're very difficult to achieve for a lot of people. So we want anybody with asthma to lead a normal life. We want them to go to work and school without any significant absences. We also want them to be physically active. So if anybody tells you that because you have asthma you shouldn't play sports, well, frankly, they're just wrong. We also want to keep you healthy. We want to reduce asthma attacks or exacerbations from occurring. We want to keep you out of the emergency room in the hospital. If anybody in the audience truly enjoys going to the emergency room in the hospital, then, well, I don't know what to say about that, but most people don't enjoy that experience. We want you to be active and physical, and we also want to maintain your lung function as close to normal levels as possible. And then also, if we're going to treat with asthma medications, then we want to try to avoid any side effects. That's why it's also important to meet with your physician on a regular basis, because a lot of times if you're doing really well, you can taper medications over time and reduce the dose. And then unfortunately, in 2013, people in America and in the world still die from asthma every year, with estimates from 3,000 to 5,000 asthma-related deaths in the United States on an annual basis. We want to prevent that. Every one of those is preventable. So in order to achieve well-controlled asthma, here's what we're looking at. You use your albuterol as a reliever less than twice a week. That's really important to understand because if you have well-controlled asthma, you're still going to have to use your albuterol. That's what asthma is. Now hopefully it won't be frequent and you won't have severe symptoms, but I want you to use it if you have any problems. It's okay to use prior to exercise if necessary because that can help prevent symptoms during exercise. We want you to sleep at night without waking up, so these are the rule of twos. So asthma as a reliever less than twice a week, waking up at night less than twice a month. And we want to keep you out of the ER. So we want to keep you off oral steroids, also called prednisone, keep you out of the hospital as well. Now in order to achieve those goals, a lot of people have to take a daily medication, which we'll talk about soon, avoid your triggers, and then see your physician on a regular basis. So there's a little bit of work. There's a lot of learning and education involved, but most people can achieve these goals. Now, in regards to the medications, as I mentioned before, anybody with asthma should have some form of albuterol immediately available at all times in case symptoms occur, because this is what's going to make you feel better. Albuterol is the mainstay. There's also a medication called Zopanex, which is available in some places. Other names for albuterol, this is where it gets confusing. It can be also be called Proventil, ProAir, or Ventolin. These are all essentially the same. This provides rapid relief of symptoms. It works within about 15 minutes, but only lasts 3 to 4 hours. So it needs to be redosed if you're having any problems. This opens up the airways. So on one of the earlier slides I showed you the constriction of the muscles around the breathing tubes. Albuterol opens those muscles up. That's what causes symptoms for people, and the albuterol relieves those symptoms. But it does not treat the inflammation. So on the slide before the bronchioles, I showed you that big red star in the middle that had inflammation at the center of it. That's what's going on in the center of anybody with asthma is inflammation. It can also be used to prevent symptoms if you know you're going to have symptoms. While we're on the albuterol slide, I will say that this, in general, works much better the earlier you use it, and as I mentioned, you have to repeat it. So a lot of families will tell me, my child was sick with a cold, they started coughing, 3 days later I tried albuterol, it didn't provide any relief, we had to go to the ER. Well, it's almost too late at that point because their muscles are so tight and spasmed that you're not going to make much of a difference. So the earlier you use albuterol, the better. It's not an emergency inhaler, it's a reliever inhaler. Now, who do we prescribe a controller medicine for? So really at the heart of it, it's anybody who's not achieving their goals of therapy. So if they're ending up in the ER, they're having exacerbations, they're missing a lot of school, they're waking up at night. There are other factors involved, but that's a good rule of thumb about who would benefit from a controller. Now, if your doctor prescribes a controller medicine, this really needs to be taken every single day to offer benefit. This does not have an onset of action like albuterol where it kicks in within 15 minutes, but over time, if you're consistent with your use, it can help decrease the inflammation inside the lungs. The most effective across the board and the most commonly prescribed are inhaled steroids. We're going to talk about this in a little bit. They treat the inflammation regardless of the cause. There are other types of controller medications available, one of which is called Singulair or Montelukast. That targets one specific chemical inside the body that can cause inflammation and asthma. For some people, it's the magic drug. It works very well, but it doesn't treat all causes of inflammation. Controller medications are difficult to take. It's like having high blood pressure or high cholesterol and having to take a medicine every single day even if you feel okay. That's exactly what needs to be done with these controller medications as well to help decrease the inflammation. And then as I mentioned, you can't really start them as soon as you start to have symptoms because it takes them a while to kind of kick in and start to have benefit. Now, when I mentioned steroids, a lot of parents have significant concerns about side effects. What I can tell you, and we're going to talk about some of these, is it's not the same as anabolic steroids. So it's not going to turn your child into this. Anabolic steroids are used for muscle growth, and they have significant side effects throughout the body, including hair loss and aggression and things like that. These are completely different. And in fact, each and every one of us actually have forms of steroids in our own body. We make these naturally. But when we use inhaled steroids, what we're doing is we're taking the steroid and we're delivering it directly to the lungs, where it can decrease the inflammation. There is a risk of side effects. Most commonly, as it bypasses the mouth and throat, it can get deposited there and cause side effects such as a white coating on the tongue called thrush. It can also cause some people to have some hoarseness to their voice and actually a reflex cough. That tends to get better with time. We also ask that you rinse your mouth and spit after using the inhaled steroid to help decrease that deposition. Less commonly, when used over time and at higher doses, children may not grow quite as tall. Now, we used to think this was sort of a temporary effect and that it went away and you were able to catch up, but recent literature has shown that this may be a persistent effect. We don't really know exactly who this will affect and when, but we do know that the higher the dose of inhaled steroids you use, the more likely that this will occur, the more possible this is to occur. The difference is really half an inch. Higher doses are directly related to the risk of side effects across the board. So that's why we try to taper the dose as much as possible and use other medications if we can. And also the type of inhaled steroid, there's probably 8 to 10 different types of inhaled steroids, and the delivery vehicle you use may actually affect the risk of side effect. Now, one way to lower the risk of side effect is to use something called a spacer. There are various types out there. This is just one example called an aero chamber. What this does is it helps the medication turn into a fine mist that you can then inhale slowly so it gets deposited deep inside the lungs. In addition, anybody with steroids, inhaled steroids should rinse and spit after using, as I mentioned before. We always try to taper the dose. And then there are medications called long-acting beta agonists. So basically, 12-hour duration form of albuterol that can be combined with inhaled steroids that is very effective across the board. The most common agents, there's 3 of them, Advair, is something you may be familiar with. Other ones are called Symbicort and then also Dulera. So there's 3 different combination agents. Now we always have to consider the risk of not controlling asthma and those side effects. So what happens if we opt not to use an inhaled steroid and your asthma is poorly controlled? Well, you're not going to sleep well. You're not going to be able to be very active and participate in activities. You're going to miss a lot of school and a lot of work because of this. You're more likely going to need oral steroids or prednisone, which, by the way, every time you get a course of prednisone, that's pretty much a year's worth of inhaled steroid, even if you take it every day. And the side effects associated with oral steroids or even IV steroids in the hospital are much higher than with inhaled steroids. So we want to try to avoid those as much as possible. There's a risk for having asthma attacks or exacerbation, and if you don't have well-controlled asthma, those are the patients who are at risk of having death from it. So that's always something that has to be weighed in the equation. Now, a lot of parents are doing the right thing. They meet with a doctor and they say, okay, I'm going to give my child the medication that you prescribed, and we're going to do it every single day, twice a day, just like you recommended, and their children still aren't doing well and their asthma is not well controlled. A big reason for that is because they're not actually using the inhalers appropriately. So there's a technique involved, and there's a lot of education and learning in regards to asthma. So if you're not using your inhaler the right way, you're not getting the medicine where it needs to go. And this increases your risk of hospitalization, ER visits, oral steroids, and poorly controlled asthma. Here's just an example of the different devices. This is the most common one. This is what your basic inhaler is called, and this is or your puffer. And this would attach to a space to deliver the medicine. There's also dry powdered inhalers, and this is an example of Pulmicort. This is a turbohaler where you kind of turn the device to activate it, and then you inhale it very rapidly and deep inside the lungs. There's another example of a dry powder inhaler for an inhaled steroid called Asthmanex. These are just a few examples, by no means inclusive. And then this is a discus that also has a dry powder where you actually click the little knob on top to activate it, and you hold it like a hamburger and you suck like a milkshake. So something that happens frequently on our end from a prescribing physician is we just prescribe a medicine, and sometimes there's no thought involved in regards to the teaching of the technique. And as you can see from looking at these 4 different devices, the technique can be extremely different depending upon what the medication is. I'm sorry, the last one is a nebulizer. So you can also deliver medications through a nebulizer, which you can hook up to some tubing. Ideally, you'll have a face mask on. Anybody who's using blow-by or just holding it in front of the face to deliver medicine, you are actually giving more medicine to the air around you than you are to the person you're trying to give it to. So we'll talk about spacers for a second. This is just one example of how to give a spacer. We can use it down to any age, even 6 months or greater. And there are different types. You can have a spacer with a face mask on it so it fits over the nose and the mouth, and then spacers just with the mouthpiece for older children and adults. This is a nice little graphic where if you just use the inhaler by itself on the top, you see very little of the medication actually gets inside the lungs. And then if you actually add the spacer, the way I think about it, it takes roughly 4 inches for the medicine in the canister to turn from a liquid into a mist that you can breathe in. If you just put it in your mouth without a spacer, most of the medicine is going to hit the back of your throat before it gets a chance to turn into a mist, and then it's going to end up in your stomach as opposed to your lungs. And then if you have any pets with asthma, you can also use it for them as well. So asthma action plan. This is something that's very important for standardizing communication from the healthcare practitioner to the family, and then this can also be shared with schools or any other caregivers. And this is just one example. There are multiple different types of asthma action plans available. As long as they have a couple key elements, it doesn't matter where you get them from. The key elements include, who's this for? Who do I call if I have an issue? What are my daily medications and how do I take them? And then the nuts and bolts of it is what happens when I start to have problems. So there should be some variation of a green zone, all systems go, I'm feeling fine, don't need to do anything differently. A yellow zone is when you start to have problems, what do you do to help prevent any severe episodes from happening? And then the red zone is really what happens when you start to have severe symptoms, what's the plan and indications when you may need to call 911 or seek emergency medical treatment. Now I use this action plan as an example for a reason, because in the middle of the screen you're going to see a little diagram there, and what that's diagramming is a peak flow meter. Now peak flow meters are not used universally for patients with asthma. We don't use them in my institution, we didn't use them in any of the hospitals I worked at previously. Part of the reason why is because with a peak flow meter, somebody just takes a deep breath in, they blow out as hard as they can, and they compare their number to their personal best. And there can be different zones about where your number may match a baseline, and that can help indicate when you're having squeezing of the muscles in the lungs or onset of asthma symptoms. It is entirely effort dependent. So if Johnny wakes up and he doesn't feel like blowing a very good number, he's not going to blow a very good number. And what happens is this can present confusion to families about what do you do, because he may otherwise feel fine, but then you have a lousy number on your peak flow meter. Personally, I'm not against them by any stretch. I think they can be a useful adjunct. I just don't think that a peak flow number by itself should really be used. It should be used in conjunction with monitoring of symptoms and understanding really when to treat asthma and how to treat it. So there are some barriers to effective care. For a lot of families, life is hard. Taking care of their child's asthma, their own asthma, is just not at the top of the list. Especially with the economic problems we've had in our country over the last few years, there can be issues in regards to having the finances to obtain medication, to even make it to the doctor. There can be a lot of stressors involved, multiple different children at home, especially multiple different children with various medical conditions. And a lot of times there are multiple caregivers. So a child may be cared for by 4 adults within 24 hours, and they may have various levels of understanding in regards to asthma care. The other thing is that asthma is a chronic illness, and anybody who has a chronic illness knows that it's really difficult to stay on top of it every single day. Most of the time you're going to feel fine, so you can just get frustrated with needing to take a medicine when you feel okay, or a lot of people, especially teenagers, just get frustrated with being sick. I don't want to be sick anymore. I'm tired of taking this medicine, and that's when you start to encounter problems. The understanding regarding asthma is just very poor across the board. As a healthcare institution, I think we do a poor job of providing education. Part of the reason is because there's so much that goes into it and it's very complex, and everybody has their own style of learning, so really addressing that is very important. And then really if you go home and you're exposed to multiple different triggers, it may not matter what medication you're taking and how you're taking it, because if you're always breathing in things that are irritating your lungs, you're not going to achieve good control. So is there any hope? Well, we know that about 1/3 of all children and toddlers are going to wheeze at some point. 1/3 of them are going to have persistent asthma through their teenage years. So that's a lot of children. I mentioned before about 10 to 30% of the general population. As a general rule with allergies and asthma, boys tend to get better as they go through childhood. So boys dominate when they're young. As they enter their teenage years, they tend to improve, and then girls tend to worsen. So we see sort of a flip-flop as far as who's worse around the adolescent time period. Now, if there's a family history of allergies, eczema, and asthma, those children who have wheezing when they're younger are more likely going to have persistent wheezing and asthma as they get older. If the child is otherwise allergic, so if they have a history of eczema or food allergies or environmental allergies, it's more likely that they're going to have persistent asthma. And then wheezing with colds and upper respiratory infections, as I mentioned before, is the most common trigger. But those children who really start to have breathing problems aside from when they're just sick with colds, those are the ones that are more likely to go on to have persistent asthma as well. Now, a lot of families always ask me, so when will I outgrow this? Or when will you tell me that they've outgrown their asthma? So most people will say never. This is something that you should be aware of for the rest of your life. Now, you may not need to take a daily medication. You may be completely fine. But I hesitate to tell somebody they've outgrown their asthma because I want them to have albuterol available just in case. Because, as we all know, when you need it most, it's not likely going to be there. So I want to try to prevent that. But if you really hold me against the wall, I'll say, you know what, 5 years without any need for albuterol, then you may have outgrown it. You might be fine. The unfortunate thing is a lot of people will have childhood asthma, and they'll do great as teenagers and young adults, and then they'll kind of rear its ugly head again when they're in their 30s or 40s. Unfortunately, there's no way to prevent the onset of asthma, no matter what you read. We can predict who may develop asthma, as we talked about on the last couple of slides. So this is important because if there's a young child who's starting to demonstrate difficulty with colds or prolonged cough or wheezing, we can make the parents more aware of what to watch out for. We can prescribe albuterol earlier, and then if they need a controller, put them on a controller earlier, which can help prevent some of the hardship that goes along with establishing a diagnosis. We're going to transition now to talk more about asthma and food allergies. So this is where we're going to start to tie it all together. So just very briefly, I know most of the people in the audience has a child or themselves have food allergies. So why are they becoming more common? We don't really have any clear answers. We also know that allergies and asthma as a whole are on the rise. There's a hypothesis called the hygiene hypothesis, which basically states that as society has become cleaner and we're moving away from rural and farm environments, our immune systems aren't being challenged by sort of typical things in the environment like bacteria and endotoxins, and then now we're harmless allergens. We may have actually done a disservice. There were recommendations over the last couple of decades to delay the onset of introduction. There was a rule of no milk till 1, no eggs till 2, no nuts or fish till 3. Well, we actually used to think that that would help prevent the onset of allergy, and now the thinking has shifted 180 degrees where we think early introduction may actually help promote tolerance. And we know that in Israel, for instance, peanut allergy is exceptionally rare. And most Israeli children will eat a boiled peanut snack beginning 6 to 8 months of age, and they'll just kind of chew on it as they're teething. So they have higher exposure in early age, and the risk is tenfold higher when looking at age-matched controls in Britain. There's some guesses regarding the manner of food production. So in the United States of America, there's a lot of roasting of peanuts, as opposed to Asia and other parts of the world where they boil their peanuts. And roasting, you heat up to very high temperature. Maybe this helps present the allergen a little bit more, or changes the allergen. None of this has been confirmed, but these are all different hypotheses. Now, as the audience I'm sure is well aware, there are relatively few foods that account for the majority of food allergy reactions. So the top 8. So cow's milk, hen's egg, peanut, tree nuts, soy, wheat, fish, and shellfish account for more than 90% of all food allergy reactions. Similar in adults, but it shifts a little bit. So you can have adult onset food allergy as well. It can present at any time. More often than not, this is going to be peanuts, tree nuts, fish, and shellfish. And mollusks are just things like clams and oysters and things like that. Now, despite sort of common beliefs, these are really misperceptions that very rare causes of food allergy include things such as food additives and artificial coloring and dyes, and preservatives and spices. It's usually going to be a major food protein or something like that. All right, so this slide I love, so I wanted to include it. This is from Scott Sisher, who's one of the gurus of food allergy, and this was published about 6 years ago. So this just shows the complexity regarding the increased rise in peanut allergy in society. I won't go through it in any detail, but I wanted to present it to the audience just to kind of show you various different theories regarding type of exposure. Are you exposed through the skin if you have bad eczema? Does it happen during pregnancy or breastfeeding? Is the timing of it? Is it if you give peanut at an early age, you prevent it, or if you ingest it later, it actually causes it? Antacids can alter the stomach lining and the sensitization patterns, the manner of processing. It's a very complicated issue, unfortunately. I regret to inform you we have no clear-cut answers right now, but there are people working on it. So the allergic march. Many of you know what this means. What this typically means is eczema, early in infancy, typically presents around 2 or 3 months of age, and then can become very severe in some children before the age of 1. Then food allergies are going to kind of start to present as kids start to eat more. So this is typically early in infancy when they may have the onset, but this can present at any time as well. And then these kids will transition. And a lot of times eczema improves significantly with age, especially by school age. And food allergies can often improve as well, but not for everybody. And then these same children will start to develop environmental allergies and respiratory symptoms with allergic rhinitis and asthma. So this often goes within the same individual and within families as well. Now, food allergies are a risk factor for the development of asthma, just as they're a risk factor for other types of allergy and things like that. As I just mentioned, food allergies typically present much earlier in life. So it's really difficult to diagnose asthma as someone in less than 6 months because, as I mentioned earlier, you have to have a recurrent and reproducible pattern of breathing problems. So you need some time for that pattern to establish itself. If you have a history of eczema and food allergies, that's a very strong risk factor for the development of asthma. And then children who have food allergies may actually start to have asthma earlier in life as opposed to other children who don't have food allergies. Now I'm just going to take one slide, and Kids with Food Allergies was very kind to invite me to write a blog post on this topic, and there's a link on their website regarding the very important difference between sensitization versus allergy. And a lot of people are diagnosed as having food allergies just by blood testing. Now this can be done either in the setting of eczema or for various reasons or as a screening tool. But by and large, just doing a blood test without taking the history into account or considering skin prick testing is not a reliable tool to diagnose food allergy. The reason why is because sensitization is basically the detection of specific IgE, which is the allergy antibody, by any form of testing. So it's a positive allergy test by itself. Whereas allergy is, I have a good history, we'll talk about that in a minute, and I have a positive allergy test. The best test for food allergy is what happens when you eat it. If you're eating a food and it doesn't cause any problems, then it doesn't cause an IgE-mediated allergic reaction. So that's the best test. So having food taken out of the diet based upon a blood IgE is just wrong, frankly, and it can lead to misdiagnosis, misunderstanding, and unnecessary dietary elimination. Now, food allergy reactions, if they're IgE-mediated reactions, these are immediate onset, can but rarely occur greater than 3 hours after ingestion, and it's going to happen every time. So if you have a milk allergy, then you should have symptoms every time you eat milk, no matter what form, including drinking milk, eating ice cream, eating cheese, eating yogurt. So that's the best example I like to give. There's really no safe threshold of ingestion, and I see this all the time when I perform food challenges in the office. Some people can react to trace amounts. Other people can have a couple of bites before they have a reaction. I don't recommend that you test this out to find out what your threshold is. It varies by individual, and unfortunately, it can vary over time as well. So with future exposures, it may take much less to provoke a similar or worse reaction. As a general rule, and I like to speak in generalities knowing that there absolutely are outliers or exceptions out there, but you typically have to have ingestion to cause a severe, rapidly progressive allergic or anaphylactic reaction. We're going to talk more about this in a little while. Casual contact can provoke symptoms as well. So if you touch something you're allergic to, you're more than likely going to get a rash or hives in that area. If you touch that and then unknowingly touch your face, guess what? You're probably going to have a swollen eye or potentially swollen lips. Now, if you touch that and then you put your hands in your mouth and you ingest a lot of it, then yes, that could potentially cause a more severe reaction. But as a general rule, we don't see that causing anaphylaxis. Same thing with breathing it in. It can cause respiratory symptoms or breathing problems, but it's very unusual for the inhalation by itself of a food allergen to cause an anaphylactic reaction. Now, what about food allergy reactions in asthma? So there's a lot of stuff on the internet, and there's a lot of other people, actually, including primary care physicians, who believe that chronic ingestion of a food may worsen asthma symptoms, and this simply is not the case. I was unable to detect any relevant scientific evidence that shows that chronic ingestion of food can cause chronic asthma symptoms. We'll talk about why in just a minute. Symptoms from food allergy are either there or they're not there. So you heard me say that if you can eat a food without any problems, you're not allergic to it. So you should know what you're allergic to, or at least be able to narrow it down to a certain meal based upon the timing of the symptoms and the types of symptoms that you have. So if a food ingestion is causing symptoms that include asthma, then your story should be, I was eating this, and while I was eating that meal or shortly thereafter, I started to have these symptoms. So it's unlikely that chronic ingestion is going to cause coughing days later or things like that. Now, if you have a food allergy and you also have asthma, then it's possible that inhalation of the food particle can cause asthma symptoms. Now, this can occur with food allergy in general, but usually what's going to happen is you have asthma, you have those twitchy airways, your body is used to producing this sort of response when exposed to allergens. Typically, this requires a method for the food protein to become airborne and dispersed. So you have to cook it, typically on the stove top, not inside the oven. Frying food notoriously can cause these symptoms, especially with fish. You'll read about this. I see this all the time. So fish protein becomes aerosolized very easily. And I have a lot of patients when they walk in the house, they know when mom is cooking something on the stove because they start to cough and wheeze very easily. There are also occupational hazards with some people with food allergy and asthma. There's a good example of baker's asthma from working with wheat and pounding the dough, and then it becomes airborne and you inhale the wheat dust. It can actually cause asthma symptoms as well. Now, with casual contact, this risk is very minimal, i.e., if you have a peanut allergy and somebody across the room or somebody in the same room as you is eating a peanut butter and jelly sandwich, it's very unusual for that peanut to become airborne to cause bronchospasm and twitching of the airways. Again, this is a general rule, realizing that there are exceptions to the rule, but casual contact typically does not cause those reactions. As I mentioned before, food-induced asthma is very rare, and if you try to reproduce it, less than 5% of people will have symptoms solely of asthma from ingestion of a food, even as an acute symptom. It's perceived to be much more common, and there's a whole host of misinformation on the internet if you actually investigate this, so proceed with caution if you go in that direction. And they have shown that various studies, if you think you're having the food is causing your asthma, well, take it out of your diet, and those people don't get better. Dietary intervention doesn't seem to work. Now, there's one exception I want to present. It's called sulfite sensitivity. Some estimates have up to 5 or 10% of adults with asthma. Now, sulfite is a chemical that's present in a lot of different foods. It's used as a preservative. The FDA banned it from use in salad bars and different things. So it keeps the lettuce from turning brown, essentially. So you don't encounter it quite as often out in the public, but it is still present in a lot of different food. This is not a true allergic reaction. There's no test for this, unfortunately. So I can't do a skin test or blood test to tell you. The only way is by history. There are different resources available on the internet, but some high sulfite containing foods would be any dried fruit or vegetable. So in the drying process, it can add some sulfites to it. Potatoes, wine and beer and alcohol can actually do this, so you can have isolated asthma symptoms from drinking white wine, shrimp as well, and some pickled foods. Now, in regards to food allergy reactions, this is from the movie Hitch, if anybody's seen it. Typically, you're going to experience some form of skin manifestation. 90 to 95% of reactions, but not all, will have big red itchy hives. Histamine is the chemical that gets released during a food allergy reaction that causes itching, swelling, things like that. You can have swelling, both external and internal, swelling of the eyes, lips, of the throat. You have nausea and vomiting. You can just have runny nose, itchy, watery eyes. It can look like an allergic reaction to grass pollen, but provoked by eating a food. You absolutely can have wheezing and difficulty breathing as well, difficulty swallowing, loss of consciousness, anaphylaxis. So anaphylaxis is important to understand and recognize because this is what is a severe, sudden onset, rapidly progressive, involving 2 or more organ systems. So what that means is you can be covered head to toe in the worst hives you ever imagined, but not have any other symptoms. That's not anaphylaxis. But as soon as you start to develop anything else, including cough, runny nose, upset stomach, vomiting, that's anaphylaxis. Typically, you have to eat the food for it to cause that reaction. For anaphylaxis, the only treatment is epinephrine. That's the first-line treatment. This is poorly understood from families with food allergies. This is poorly understood from EMS workers and our own emergency physician doctors. Oftentimes, we'll see anaphylaxis and they treat it with Benadryl. If you give epinephrine and the symptoms persist after 5 minutes or so, or they return, the treatment is epinephrine. If you're not sure what to do, the treatment is epinephrine. And then you must call 911, make sure that they have epinephrine available because there are certain areas in our country they don't stock epinephrine on their squads, and you have to be taken to emergency room for observation for at least 4 to 6 hours because there is a risk for symptoms coming back in what's called a biphasic reaction. Now, for food-triggered anaphylaxis, having asthma is a risk factor because you're more likely going to have associated breathing problems. And as I just mentioned, anaphylaxis is more than one organ system. So if your airways are already twitchy to begin with, and during an allergic reaction, your body's going into overdrive, you're more than likely going to have twitchy airways in association with your hives or swelling or anything else. So that would give you risk for anaphylaxis. Different foods are more likely to cause anaphylaxis, especially peanuts, tree nuts, fish, and shellfish. But I want to make sure everybody is completely clear that any food allergen can cause anaphylaxis. There are unfortunately a lot of people who have had anaphylaxis to milk, egg, soy, other foods as well. The amount ingested, obviously if you eat more of it, it's more likely going to provoke a severe allergic reaction, but even trace amounts can provoke anaphylaxis in some. Now unfortunately people do die from food allergy reactions in the United States. This is roughly maybe 200 people a year. This is really difficult to know for sure because of the inconsistency with reporting on death certificates. So they may put anaphylaxis, but they may not put food allergy-induced anaphylaxis. So it could have been from a bee sting or medication, something like that. However, there's a common theme that appears. Risk factors for death, delayed administration of epinephrine. You wait too long. In fact, people who wait more than 5 or 10 minutes, their risk of death goes up considerably. If you have asthma, it also places you at risk for developing fatal or near-fatal food allergy reactions just because of the airway component. Teenagers and young adults are at higher risk. A lot of this has to do more with not having epinephrine available and risk-taking behavior, things like that, and then the type of food allergen. So as an example, it's very unusual for pears to cause food allergy death, but it's much more likely for peanuts and tree nuts. Now, proper diagnosis is crucial because you need to know exactly what to avoid, because unfortunately the only treatment currently available is complete and strict avoidance of the food. So meeting with a board-certified allergist can be very helpful to make sure you have the appropriate skin prick or blood testing, and then oral food challenges can be helpful when the diagnosis is in question. You need to strictly avoid it, which means reading labels. I'm sure the audience is very well aware of how to read labels and what to look for. Also discussing with food handlers at restaurants and bakeries about cross-contamination. Having a food allergy treatment plan for school. So even if you have asthma, you need to have an asthma action plan for school as well. And if you have food allergy, you need to have a separate plan available at school because they're very different in management. And then educating family and caregivers and anybody regarding the importance of avoidance and treatment. And I'm sure everybody in the audience is well aware of the anxiety that is provoked whenever your child with food allergy goes on a visits somebody for a birthday party, or even you visit relatives over the holidays. So everybody needs to be aware that even a small amount can cause problems. This is a recently updated example of a food allergy treatment plan. It has the name, it has what you're allergic to and the weight. And if you look on the left-hand side for any of the severe symptoms, it says give epinephrine. I like to highlight one addition. When in doubt, give epinephrine. You already heard me say that before. If you have severe symptoms or anaphylaxis, inject epinephrine immediately and call 911. So without a doubt, those are the two things that need to be done. And this is highlighted as well. So do not depend on antihistamines or inhalers to treat a severe reaction. Use epinephrine. Anaphylaxis means treatment with epinephrine is mandatory. And on the back, it just shows various ways to give the different types of epinephrine auto-injectors, which we'll talk about in a second. This can become very confusing very quickly. You heard me say before that if you have a food allergy, less than 5% of people will present just with asthma symptoms. It can happen, but it's extremely rare. So if it's just coughing, wheezing, or breathing problems without anything else, it's probably asthma, and you can treat it with albuterol. Any other symptoms plus breathing problems, start to think about a food allergy reaction, but take it all into account. So what was going on? Were they eating at the time or immediately before? That's more likely going to be a food allergy. If it had no relationship with food ingestion and they wake up in the middle of the night and they haven't eaten for 6 hours, it's less likely to be a food allergy, especially if it's just isolated breathing problems. And then chronic symptoms that are going on, we already talked about how it's unlikely that ingestion of food will lead to chronic problems, so think more asthma. So when do you give albuterol during a food allergy reaction? To be totally honest with you, there's probably no realistic case where you would give albuterol, and we'll talk about why. So albuterol relieves the coughing, wheezing, shortness of breath. It's unlikely that this will occur in isolation. Anything else, epinephrine is necessary, and repeat it. Oh, by the way, if you're worried that you're going to treat asthma with epinephrine instead of albuterol, you're still going to make them feel better. This is something that's used routinely in emergency rooms and hospitals throughout the country because it's very effective at relieving the spasming of the muscles in the lungs. This will also work in all systems very rapidly. It opens the airways. It's actually more effective than albuterol. Now, I don't want you giving your child an EpiPen every time they have asthma symptoms. That's not what I'm saying here. But what I am saying is that if you're really questioning yourself and it's a potential food allergy reaction or especially anaphylaxis, give them epinephrine. And don't think of that as harmful when you're treating a food allergy reaction because this will save their life. And the earlier administration, the more effective it is. So Benadryl, Everybody sort of has a pattern. Now, at any time, a food allergy reaction can progress with the next ingestion, but there are a lot of people who have similar and reproducible symptoms. So, in other words, I'm allergic to milk. If I'm accidentally exposed to it, I develop hives, and that's happened repeatedly, so that seems to be the case. So sometimes it's very appropriate just to give Benadryl if it's hives, or even if it's just hives without anything else, it can be appropriate to give Benadryl. Once you start vomiting, wheezing, having anything else, then you need to use epinephrine. It can worsen with each ingestion, so it can give a false sense of comfort as well. So if you give Benadryl, don't think you're out of the woods. They absolutely warrant close monitoring and observation, and then things can progress next time. Now, in regards to self-injectable epinephrine, this needs to be immediately available at all times. School, home, when at restaurants, when at the park, everywhere you go, because you never know when you could accidentally encounter a food allergen. Risk factor for severe or fatal food allergy reactions is when epinephrine was delayed in being administered. Right now, EpiPen, Auvi-Q, and Adrenaclick are the three major ones available. There's a new pharmacy rule where if the physician doesn't specify and say dispense is written and say they prescribe Auvi-Q, that pharmacies can actually replace that with Adrenaclick, the generic version. So make sure that you specify that. You're not caught off guard if you're used to using a particular product. Every time it's given, you need to seek emergency medical care. This is a great chart from kids with food allergies. I put the link on there that just really talks about the difference between the different types of epinephrine autoinjectors and all that fun stuff. There's a link for you to go as well. Okay, so in case you missed it, treatment of severe or rapidly progressive food allergy reaction is epinephrine. In case you missed that, it's epinephrine. Oh, by the way, the treatment of anaphylaxis is epinephrine. What's that you say? You want to give epinephrine? So, all right, everybody gets the point now. So I say this kind of joking, but I'm completely serious that this is a problem. People are not using epinephrine when it should be administered, and when in doubt, give epinephrine. So in regards to school, communication is key. So I recommend verbal and written communication. So verbal communication before school with administrators and also the teachers to let them know exactly what you're dealing with. Also the written treatment, copy of that, because what's going to happen is I'm sure your child will be fine, and then if something does occur, it's going to be months later, and they may just not remember your conversation. So it's nice if they have actually something to refer to in a rapid manner. 504 plans are available. They're not always necessary, but this is something that the school district is legally required to provide certain provisions, including assigning somebody to make sure that they can monitor for food allergy reactions and give epinephrine if necessary. Every year, these treatment plans should be updated because things can change, including weight. So the EpiPen weight indication changes once kids get a little bit heavier, around 66 pounds or so. And then make sure that their medication is available as well, because these do expire over time. And here's a couple resources in regards to asthma. And then that's all I have. So I'm going to turn it back over to Melanie or Linda. And I can't thank you enough for showing up today and all of your attention.
Thanks, Dr. Dave. What a wonderful presentation. So packed full of information. We've gotten a lot of questions during your session. So in addition to all the new information I'm sure we've all learned, there's some additional questions. Hopefully we'll have a few minutes to ask you after we do some giveaways. So I realize that meticulous asthma management is so important when we've got food allergic kids, and I have a child with food allergy and asthma, so I know how important this topic is. So I thank you for taking the time to be here with us today. So what I'm going to do is try to give away these items from Dr. Lucy and from Enjoy Life, and then we'll move back to questions and answers with Dr. Dave. So for Dr. Lucy, each of you will get a gift pack for the ones for which we announced the winners, and same thing with Enjoy Life Foods. So I'm waiting to hear the names of those who win. Do you have those names for me, Melanie? Oh, the Dr. Lucy winners are Amy Prater and Carrie Kinchata. I'm sorry if I've mispronounced your names. And the Enjoy Life winners, I think we have another slide for Enjoy Life. There you go. Each sponsor is sending a gift pack of allergy-friendly products, and the winners for the Enjoy Life products are Nicole Vargas and Tamara Hubbard. So thank you all for joining us, and congratulations on winning those. So now what we'll do is move on to some questions and answers. So let's see what we've got. Melanie, do you want to advance the next slide? Okay. Okay. What percentage of children let me see if I can read this question here, who've died from anaphylaxis also have had asthma?
So that's a wonderful question, and I searched far and wide. I don't have a good answer. All I can say is that it's the majority. So I would say at least 3/4 also had asthma. This is really difficult to study because of just different ways of reporting and things like that. But it absolutely is a well-recognized and known risk factor for anaphylaxis of any cause.
Okay. Next question. Is there a final takeaway message if you're managing both asthma and food allergies, and when anaphylaxis can be confused for asthma?
Sure. So as you saw from the presentation, there's a lot that goes into this. It's complicated for families, very complicated for people not familiar with either one of these. So communication is the key, especially when other caregivers involved, such as the school environment. I really can't emphasize that enough. And working with your physician or allergist or wonderful organizations such as Kids with Food Allergies can provide you with resources to help aid that education. Because really, at some point, our children have to leave the nest and go out in the real world. So we want to arm them with the best chance to succeed that we can. And then with food allergies and anaphylaxis confused for asthma, hopefully I highlighted the importance of really anything more than breathing problems by itself. You really need to think anaphylaxis and use epinephrine. And while it can be tricky, you also won't go wrong if you accidentally use epinephrine when albuterol is indicated, and you'll then be able to follow up with your doctor and sort that out over time.
Okay. Should everyone with asthma have an action plan?
Yes. Without hesitation.
And if your child has food allergies and asthma, should you have an action plan for food allergy and an action plan for asthma?
Absolutely, because they're very different and the management is very different.
Okay. And would you, in the case of anaphylaxis, follow?
If it's anaphylaxis, you follow the anaphylaxis plan because that is the most severe and pressing issue. So it's when in doubt, that's what you go for.
Okay. Is a nebulizer better than an inhaler?
The short answer is they're equivalent. So nebulizers seem like they're better because they take 15 minutes. You see the medicine, and you just see everything kind of working. But the actual medicine delivered to the lungs is the same, if not more effective, when you use an inhaler with a spacer and the appropriate technique. And the inhaler with the spacer is portable and you don't require electricity, which is a nice feature as well.
Why are healthcare providers hesitant to diagnose asthma, or they diagnose it as reactive airway disease?
Oh, if I had the answer to that, then I would be a much happier man. So I see this all the time. This morning actually was my severe asthma clinic, and it's just a hesitancy to establish the diagnosis. I see it as an opportunity. Sometimes they're just not comfortable with it. Sometimes I'm not sure what it is, and that's why specialists that's why we're here. But I like it. I like to make the diagnosis because it really establishes the right care. So instead of going for the cough and cold medication or the nebulizer or anything else when your child's coughing, now you have an effective treatment that can actually make them feel better, and you know what to watch out for. It's very complicated, but there's still a lot of confusion and poor understanding that exists.
Okay. Can sudden onset of asthma symptoms occur even with well-controlled asthma?
They can, and it's a bit unusual, but it can occur, and that's why everybody needs to try to understand their own individual trigger. Examples of that would be exposure to a high level of allergen if you have allergies, or an irritant like cigarette smoke or pollution or something like that. And then there are some viruses that are just really good at causing asthma symptoms, including the influenza virus. And that's why it's indicated for anybody with asthma to receive the influenza vaccine every autumn, because if you get real deal influenza, it's really good at attacking the lungs and causing severe illness. Which just brought up something in my mind. So if you have a history of egg allergy, previously it was contraindicated to receive the influenza vaccine. That contraindication no longer exists. This has been studied extensively over the last 25 years, including several members of our medical advisory team who have contributed significantly to this field. Bottom line is, the influenza vaccines currently available through injection do not contain a sufficient amount of egg protein to cause a severe allergic reaction. By and large, if you're eating baked egg, you can get it no matter what. If you've never had anaphylaxis, you get it no matter what. There's still some controversy if you have a history of anaphylaxis to egg that some people recommend you receive your influenza vaccine from an allergist, but even then it seems to be safe.
Okay. For an asthma spacer, an inhaler spacer, is that something your doctor needs to prescribe, or can you get one on your own?
For the most part, they need to prescribe it because they can be quite costly if you try to purchase it out of pocket. So that's the easiest way is to discuss with them.
Okay. Does Zopanex cause less jitteriness than albuterol?
Oh, if you look at the science, no, but a lot of people will tell you that it may. The jitteriness with albuterol tends to improve with time, and unfortunately the more you use it. So that tends to get better. There are some people who are exquisitely sensitive to various types of medications. The only way to know is by trial and error. So sometimes the switch is necessary.
Okay. Can you become desensitized to albuterol?
Most people cannot. There are some people that have a genetic mutation in their albuterol receptor that the more they use albuterol, the worse they get. We currently don't have any way to test for that or to determine that until pretty much after the fact, and your physician has to be pretty astute as well. But if you're using albuterol all the time and your child's no better, regardless, that's a strong indication to talk to the doctor because something's not right.
Okay. And then somebody was just saying that she attended an educational presentation by an allergist who was saying that anaphylaxis doesn't necessarily have to involve two body systems. Can you comment on that?
Yeah, so there's various severities and grading of anaphylaxis. Every individual is a little bit different, but if you have rapidly progressive symptoms, then that's a good sign that you're having a severe allergic reaction. If you eat something and you have one or two hives appear, but they don't seem to progress, then that is an indication that it may not progress to an anaphylactic reaction. I think the reason to families that anaphylaxis doesn't necessarily have to have two, so don't wait around for the second one to develop. If your child's sitting in front of you and they're having a potentially severe sudden onset rapidly progressive reaction, treat them with epinephrine. That's always going to win out no matter what.
Okay. It's a little after 2 o'clock, so I'll just try to pick one more question. Someone who was asking you to comment about the use of Xolair for allergic asthma.
Sure. So Xolair's been around for about a decade. It's an injection that it actually binds and blocks the IgE molecule. So it's indicated right now for children 12 years of age and older who have severe refractory allergic asthma, meaning that they're poorly controlled despite taking daily controller medications, and they have evidence of allergic sensitization to at least one indoor allergen, including cat, dog, dust mite, or cockroach. And what Xolair does over time is for the right patient, it can help significantly improve their asthma control, keep them out of the hospital, keep them off oral steroids. Eventually you can decrease their dose of inhaled steroid and things like that. It doesn't work for everybody, but it seems to be effective for about 60% of patients. That's a great question.
Okay, terrific. Well, I'm just going to have, there's just so many questions that have come in, we could probably be here for another hour, so I'm just going to say thank you so much for joining us today. It's been a really enlightening presentation. I know I've learned a lot. The archive of this webinar will be available in a couple of days, and we will email it to all of you who've attended today, as well as any who have registered but not gotten a chance to log in. Our next webinar will be on Monday, November 18th at 4 p.m. Save the date. We will be announcing the topic next week. It's a research update, and I think you'll be really excited to know about what we'll be talking about. And lastly, I want to thank Dr. Dave for joining us here today. It's been really wonderful having you, and we're very honored to have your time.
Well, thank you so much. It's a pleasure to be here.
Sure. I'd like to close with just a few last comments. Kids with Food Allergies is part of the Asthma and Allergy Foundation of America, the nation's oldest and largest asthma and allergy charity. If you have found today's session valuable and would like to see us continue this webinar series, please consider making a donation to support kids with food allergies in your end-of-the-year giving plans. Thank you for joining us here today. I'm going to go ahead and close the session, and like I said, we'll be following up with an email with the links to all the various things we've talked about today, as well as the archive to the webinar. Thank you all.